Hello and welcome everyone. Today we'll be discussing sepsis associated encephalopathy. Sepsis associated encephalopathy is a severe neurologic syndrome characterized by diffuse brain dysfunction due to sepsis, a life threatening condition from dysregulated body response to infection. Patients acutely present with symptoms ranging from delirium to coma. SAE is defined as an acute encephalopathy during sepsis or septic shock, which is not attributed to other causes. It is the most common cause of encephalopathy in the ICU. The landmark studies show that SAE, which is when defined as a GCS of less than 15, is observed in 54% of 50 non-sedated ICU septic patients. Now, recent cohort reports show an incidence of 53% in French ICU multicentered cohort and up to 68% in a US database. Sepsis associated delirium has a median duration of 3 days among affected participants in large multicentric study. SAE ranges from mild delirium to deep coma, affecting patients' prognosis. Its occurrence is independently associated with short-term mortality. Severity correlates with mortality, with GCS score of 3 to 8 having the worst prognosis with a hazard ratio of 3.37. Mild mental alteration, that is GCS of 13-14, also increases the risk of death, but the hazard ratio is still 1.38. So what are the risk factors? The risk factors are data on acute encephalopathy often comes from studies in general population rather than from sepsis specific studies. The identified risk factors for SAE in septic patients include various biases due to the lack of consensual definition, differing sepsis criteria. Large multicentric epidemiological studies specific to SAE are needed for more accurate identification of risk factors. These are the factors which we know as of now. There are some factors which are non-modifiable and some are which are modifiable. The non-modifiable medical risk factors are older age, CKD, alcohol abuse, history of neurological disorder or cognitive impairment, long-term use of psychoactive drugs. On ICU admission, you can have medical admission as a reason of developing this condition, mechanical ventilation, acute renal failure, bacteremia, and Staph aureus infection. During the ICU stay, bacteremia increases the risk of encephalopathy. The modifiable risk factors on ICU admission are hypoglycemia or hyperglycemia, hypercapnia, hypernatremia. Midazolam and cefepime per se increase the risk of delirium. Now, clinical evaluation. Neurological assessment in ICU is complicated by various factors because there is fever, metabolic derangement. Most commonly is the use of hypnotics and sedatives when the patient is on ventilator. So SAE manifests as a rapid change in the cognitive status, presenting a wide range of symptoms. That is mild delirium in 19% of the cases, coma in up to 40% of the cases. Hypoactive delirium is also quite common. Agitation in 10% of the cases and dysautonomia are less frequent. Seizures can also occur with focal signs. These occur very rarely, that is 2 to 1%, and are quite uncommon. Diagnosis and screening. Underdiagnosis of SAE is likely without systemic screening using validated tools. SAE may be the first sign of early sepsis, and any new onset encephalopathy should promptly the clinician to the risk of a infection. Neuroimaging. CT scans, limited data on its usefulness. Meta-analysis shows CT abnormality in 11% of acute non-traumatic encephalopathy cases. Common acute findings are infarcts and hemorrhages. Angio-CT is recommended for acute coma and brainstem involvement to rule out basilar artery occlusion. MRI indicated for focal signs, brainstem symptoms, new onset seizures, persistent encephalopathy without common confounders. Diffusion weighted imaging sequence is recommended for detecting cerebral ischemia and inflammatory changes. Acute MRI alterations in SAE are parenchymal lesions in 55%, atrophy in 16%. Ischemic lesions are diagnosed in 14 to 27%. Now, infarct pattern is multiple in seen is 67, large in 43, junctional in 29, associated with DIC and low platelet counts. White matter lesions are observed in 14 to 81%, with periventricular distribution more common. Posterior reversible encephalopathy syndrome, that is PRES, is seen in 9% of the cases. Brain atrophy is more pronounced in SAE than healthy controls. Diffusion reduction in cerebral cortex, and white matter and hippocampus volumes. So the prognostic significance: acute neuroimaging changes the prediction for disability and survival in the first year post SAE. Ischemic stroke independently associated with increased ICU mortality and poor functional outcome. Acute neuroimaging abnormalities linked to ICU and 1 year post ICU mortality and disability. Greater brain atrophy correlates with worse cognitive performance at 12 months. PRES presence is not associated with worse outcomes. So there are also EEG and evoke potential changes. In EEG, the utility is it's valuable for diagnosing SAE by excluding non-convulsive status epilepticus and for prognostication purposes. It is indicated in patients with altered mental status, seizures, and stereotyped abnormal movements. Useful in mechanically ventilated patients with delayed awakening, typically 48 hours post-sedation discontinuation. The challenges are impact of sedation on EEG. And sedatives can cause dose-dependent slowing of the EEG background. Benzodiazepine produce a diffuse rapid rhythm. The propofol and barbiturate cause low voltage discontinuous patterns and their interpretation. Early EEG abnormalities may precede clinical impairment and correlate with encephalopathy severity. Common patterns are slow background of theta and delta dominant rhythms, that is 10 to 60% of the patients, low voltage discontinuous background, that is 10 to 16%, burst suppression in 3 to 8%, and severe patterns, that is more common in sedated patients, complicate differentiation between sedation effect and SAE. Diffuse triphasic waves and periodic discharges, that is 5 to 20% of the patients. Now, pathophysiology and seizures. Electrographic seizures in SAE may relate to neuronal excitotoxicity, neurotoxic antimicrobials, and metabolic derangements and acute kidney injury. Most such seizures are non-convulsive, highlighting the importance of continuous EEG. Electrographic seizures occur in 0 to 30% of the cases. The prognostic value is that some patterns like slow delta rhythm, absent EEG, discontinuous and periodic discharges are associated with delirium and also mortality. Rapid beta waves are linked to reduced risk of delirium. Absence of reactivity is associated with ICU and 1 year mortality. Triphasic waves, slow delta waves, and suppressed EEG frequent within 24 hours before the death. Cynic scale score is associated with mortality in septic patients. Reactive EEG with a background frequency of more than 4 Hz is linked to reduced mortality post sedation interruption. Evoke potentials, the type and its usages. Neuronal response time locked to stimulus differ from EEG as they are stimulus induced. The reflex combined activity of many neurons firing together. The SSEP, that is somatosensory evoke potentials, commonly used for neuroprognostication with bilateral absence of N20, indicate poor outcome post cardiac arrest. The other types are brainstem auditory evoke potential, long latency event related potential like mismatch negativity, and P300. The diagnostic and prognostic value is that the interest in these potentials for SAE diagnosis and prognosis remains debated. Subcortical and cortical SSEP pathways impaired in significant percent of septic patients. Intracranial conduction time and intrapontile conduction time could predict ICU mortality and delirium in deeply sedated patients. Greater MMN amplitude observed in patients with awakened is compared to those who did not. Limitations. It is restricted ability to do these in the ICU. Interpretation difficulties, moderate prognostic value in septic patients. So this basically shows the prevalence and prognostic value of various EEG patterns. Sepsis associated encephalopathy and its pathogenesis. It has a multifactorial pathogenesis and its association is already, as we have discussed, seen in around 70% of the septic patients. There is a significant increase is pro-inflammatory cytokines, which is the primary cause of brain damage during sepsis. The activation of the microglia and the astrocyte alter the cerebral homeostasis. The neuroinflammation and the brain damage that follows results in inflammation and increased metabolic demand, causing oxidative stress and mitochondrial dysfunction. Production of reactive oxygen species and pro-apoptotic signals affect glial cells, neurons, and blood-brain barrier structure. The impaired blood-brain barrier integrity compromises the healthy brain function. The metabolic and hemodynamic changes. The precede cognitive disorders and structural changes in the brain, white and gray matter. The changes in cerebral metabolism are key to encephalopathy during sepsis. Blood-brain barrier damage and its dysfunction. Composed of endothelial cells, astrocyte food processes, and advential cells, it controls the cerebral blood flow. Now, overactivity of the immune response during the early sepsis causes cytokine release, activation, and the dysfunction of the endothelial cells. The tight junctions open, causing increased blood-brain permeability. So these cytokines and endokines enter this damaged endothelial cells, exacerbating the blood-brain barrier damage and promoting edema and neuronal loss. Now, the cellular and molecular mechanism, the severity of the inflammation with the blood-brain damage reduce the tight junctions. So the lipopolysaccharides binding to the toll-like receptor, that is TLR4, activate the nuclear factor kappa beta and via the MYD88 and RHOA pathways. The upregulation of the pro-inflammatory cytokines and chemokines damage the endothelial cells, worsening the blood-brain impairment. The endotoxin and cytotoxins decrease the occludin expression, altering the endothelial cells' integrity and permeability. So there are some additional mechanisms which exacerbate the damage. That is the mitochondrial dysfunction mediated by DNM1L and DRP1-FIS pathway. Now, alterations in the endothelial cells, sphingolipid metabolism, downregulation of the tight junction proteins by matrix metalloproteinases, pericyte detachment from the basement membrane, microglial activation and inflammatory response. Blood-brain barrier damage allows inflammatory mediators into the brain, activating the microglia. This overactivated microglia releases the inflammatory mediators and causes more inflammation. These factors exacerbate the inflammation and damage the blood-brain barrier further. So this diagram here contrasts the healthy brain with one affected with septic encephalopathy. It illustrates various pathological changes. So first is the neurovascular unit. In the healthy brain, here depicted by the normal structures, but as you can see here, it shows alteration in the sepsis because of the cellular damage and the inflammation. The next is the blood-brain barrier, which is intact over here. While in the septic patients, the endothelium is damaged. You can see the damaged endothelium here. The astrocytes are affected and the inflammatory cells are gaining entry into the brain. The next is the cerebral blood flow, where you can see that in the healthy brain, the normal blood flow and the oxygen is maintained, while in the septic associated encephalopathy, the cerebral blood flow leads to neuronal hypoxia, apoptosis, and bloodstream destruction and damage to the vascular endothelium. Next is the microglial activation. So the microglial activation results in which usually is in the resting state in the normal brain. It gets activated and releases pro-inflammatory markers. The next is the neurotransmitters. The neurotransmitters, which are proper neurotransmission in healthy brain. What happens in sepsis is that the neuroinflammation affects the neurons and the synaptic transmissions, leading to dysfunction in the transmission. Next is the glial cell overactivation, which again is in a resting state, but here the glial cells are getting overactivated and promoting inflammation. Finally, the leukocyte extravasation. In sepsis, the compromised blood-brain barrier allows the leukocytes to infiltrate into the brain and cause further inflammation. So all these macroscopic changes occur which make the brain defective. So now that we have seen the macroscopic, now let's see how it occurs at the microscopic and the signal transmission level. So first you can see here that the blood-brain barrier is damaged, and this damage to the blood-brain barrier and the endothelium allows the inflammatory cells to enter into the brain structure. So inside the brain there is activation of the microglia and the astrocytes, which further release pro-inflammatory cytokines. So you can see here the reactive astrocytes and the microglia. So all of these result in inflammatory cytokine release and neuronal damage. So there is a direct neuronal damage because of this cytokines. So you can see here, and further the damaged neuron also release the damage factors which act on the toll-like receptor 4 and promote inflammation. So again, you can see here the neurotransmitter disorder also occurs. The inflammatory cells are acting over here, thereby impairing the neurotransmission. Finally, you have damage to the mitochondria also. So this reactive oxygen species and NO act on the mitochondria, causing mitochondrial dysfunction and death. So based on this, we have found some of the biomarkers which can be used. The one that is commonly used is neuron specific enolase, because it has been used since a long time for prognostication of post cardiac arrest. Here, elevated neurospecific enolase more than 12.5 microgram per liter in sepsis varies from 28 to 53%. So using this neuron specific enolase, a threshold of more than 24.15 shows a 83% specificity and 54% sensitivity for diagnosis of encephalopathy. So there is a conflicting evidence on correlation with mortality. It found a study has found that there is no correlation between neuron specific enolase and 28-day mortality. Other studies link neuron specific enolase with ICU and hospital mortality. And abnormal NSE in ICU admission is associated with 23.3% risk of death. Each doubling of NSE is linked to 7.3% increase. So overall, NSE level of more than 12.5 is associated with sepsis. So the next biomarker is protein S100 beta. It's a glial injury biomarker which conflicts with prognostic values. A high PS 100 is associated with hospital mortality. Other studies found no association of this. And the other biomarker is neurofilament light. This increases over time in septic patients. Higher plasma level is linked with severity of the encephalopathy and poor long-term functional outcomes. The next is glial fibrillar acidic protein GFAP. Higher serum correlation with encephalopathy associated with sepsis with non-septic encephalopathy. This values are associated with a prediction of mortality with the area of curve around 0.77 and also worse long-term outcomes. Next, you have microRNAs, which is considered diagnostic and prognostic marker for SAE, but the clinical use remains limited. The challenges are optimum timing for the biomarkers is undefined, uncertainty about the precision of SAE onset, inconclusive findings about prognostic benefits, and definitive thresholds. Limited access to certain biomarkers impede routine clinical use. Biomarker profile differ between various patients, so we are still not very sure how to use this biomarker. Coming next to the management part, the general measures like multidisciplinary care is crucial. Prompt identification, treating with antibiotics, fluid resuscitation, and vasopressors, control the secondary brain damage, implement ABCDE bundle to prevent delirium, use sedatives or antipsychotics for agitation, and avoid midazolam as much as possible. Monitor serum concentration of potential neurotoxic drugs systematically, especially in renal failure. Now, systemic causes of secondary brain injury frequent at sepsis onset are linked to poorer outcomes. These include various parameters that we all manipulate and control in our ICUs. Follow international sepsis, post-resuscitation care, and neurocritical care guidelines for the management. Antibiotics and association. 3 phenotypes of antibiotic-associated encephalopathy occur. The acute onset encephalopathy with seizures and non-epileptic myoclonus, often linked to cephalosporin and penicillin. Encephalopathy with psychosis, which is commonly associated with quinolones, macrolides, and procaine penicillin. The subacute encephalopathy with cerebellar signs and MRI abnormalities typically associated with metronidazole. Most frequent EEG changes include diffuse slowing and generalized periodic discharges with triphasic morphology. Cefepime is frequently linked with neurologic events, especially in renal failure. The median time for neurotoxicity to develop is 4 days. Symptoms include altered mental status, myoclonus, and non-convulsive seizures. Monitor serum cefepime levels if neurotoxicity is suspected. A trough level of more than 20 increases neurotoxicity risk. Symptoms usually improve with dose reduction or discontinuation. Neurotoxic side effects are absent when the trough levels are less than 7.7 and always present when it is more than 38.1. So summarizing, this is a simplified diagnostic algorithm for SAE where you suspect sepsis, and in those patients if you find delirium or coma, then you do an initial assessment where you rule out potential contributors to this encephalopathy. Next is investigation based on the clinical signs, that is focal signs. That is, you can do neuroimaging and check for multiple ischemic strokes and white matter lesions. Then you check for fevers, meningism, bacteremia, seizures, and persistence of the encephalopathy. So these are the associated signs you look for. Next, you make a differential diagnosis based on that. Do your investigation and make a differential diagnosis. So by first suspecting, looking at associated signs, you make your investigations and then make your differentials. So what are the long-term outcomes and recovery? Severe sepsis patients often face a range of cognitive, psychiatric, physical, and social impairments. The impairments include cognitive dysfunction, psychiatric conditions, physical disability, and other problems. So the cognitive impairment, the inflammatory process contribute to the both early brain alteration and long-term cognitive impairment. Sepsis episodes are linked to increased risk of dementia. Longer duration of sepsis-associated delirium continues to be cognitive function decline at 3 to 12 months also. Hippocampal atrophy is observed in sepsis survivors with cognitive impairment. Risk factors for post-sepsis cognitive impairment, CNS infection, length of hospitalization, decompressive symptoms, older age, longer ICU stay, and mechanical ventilation. Blood biomarkers such as IL-6, IL-10, E-selectin, S100B, NSI, and interferon gamma have been associated with poor cognitive performance in ICU discharge, though the evidence still is controversial. Seizures, sepsis survivors have a higher long-term risk of seizures compared to other hospitalized patients. The annual incidence of seizure post-sepsis is around 1.29%. Now, incidence rate ratio for seizure post-sepsis is significantly higher compared to general population and hospitalized patients without sepsis. Younger sepsis survivors and those with chronic kidney disease are at higher risk of developing epilepsy. Sepsis may be an unrecognized risk factor for epilepsy, leading to permanent neurological sequelae. So this graph here basically shows the complications associated with septic associated encephalopathy over a time. So in this timeline, you have an acute phase where you have delirium, initial ICU mortality, seizures, multi-organ failure, incidence of cerebrovascular accidents, and white matter lesions. Gradually, over the period after discharge, they go on to have long-term mortality, cognitive impairment, neuropsychological sequelae, functional disability, epilepsy, as well as brain atrophy. So the neuropsychological changes. Long-term emotional and behavioral changes include depressive symptoms, anxiety, and PTSD. 12% of the sepsis survivors have PTSD at 6 months, often with delayed onset. Severity of the depressive symptoms post-ICU discharge is associated with chronic pain or post-traumatic stress. Anxiety, fatigue, sleep disturbances are very common. Primary care intervention for 12 months reduced the PTSD symptoms but did not improve the overall psychic quality of life. Functional disability risk and input. Sepsis survivors have increased risk of mortality, similar risk of new disability at 6 months compared to mechanically ventilated patients without sepsis. Higher healthcare resource use and cost, but similar survival and health-related quality of life compared to matched non-septic patients. ICU weakness also increases the functional disability in these patients because they have fatigue, muscle weakness. The overall management, to summarize, we need early detection, which is by clinical examination and EEG findings, correct the metabolic disturbances, that is the natremia, CO2, glycemia, prevent secondary brain damage, avoid neurotoxins like cefepime and midazolam, manage the acute renal failure. So finally, these are the things that we can actually do in these patients to prevent secondary brain damage, that is maintaining a MAP of 65 to 80, PaO to 80 to 120, PCO to 35 to 45, temperature 36 to 38.3, natremia 135 to 145, glycemia 5 to 10 millimoles per liter, prevent hypoglycemia, hemoglobin more than 7. So preventing all this, maintaining all this results in reduced secondary brain damage. So there are very few things that we can intervene in. Preventing the secondary brain damage is one of the most important things that we can do. Thank you for your patience.